Good morning, everyone. I think we're going to get started. Great. So good afternoon. As you know, I'm Catherine Sorsdale, and I'm the co-director of the Alan J. Flisher Center for Public Mental Health. And on behalf of Ashraf Kaji and I, we're really excited to have you for our annual Alan J. Flisher Memorial Lecture. So it's a very special day for us. We're happy to have those online and those in person. And Alison, Alan's sister, is here as well. Before we start, we usually have someone say something about Alan. And today we have Professor Quickland, who is going to do that. So, as many people already know, he is a professor of global mental health and development in the King's College Global Institute and Center for Global Mental Health at King's College. He is also an honorary professor in our center. And he was also the founding member of the Alan J. Flisher Center for Public Mental Health and was its first director for many, many years. And he was also a friend and colleague of Alan.
Thanks so much, Chris. Thank you very much, and thank you for coming. It's really wonderful to see this turnout and see how many people are joining us today to remember Alan and to celebrate his life and all his many contributions, and also to hear a wonderful guest speaker, Dr. Victoria Mutiso, who will be speaking to us shortly. So I'm just going to say a few words for those of you who didn't know Alan, just about who Alan Flisher was, and some of his many contributions to the field of public mental health and psychiatry in general. Alan was born in 1957 in Cape Town, and he first studied mathematics at UCT and then went on to study psychology. He got interested in clinical psychology and did a master's and trained as a clinical psychologist. He then decided he was interested in medicine, so he started from scratch with a medical degree. He told me later that he had no plans to do psychiatry. He was really genuinely interested in medicine, so he did medicine, and then he went on to discover an interest in psychiatry. So he trained as a psychiatrist, and then subsequently did a subspecialty training as a child psychiatrist, which he finished in 1998. He was really a consummate clinician and researcher. He really brought those two roles together. He was a dedicated consultant. He served as the consultant psychiatrist at Chris emergency psychiatry ward for 10 years before joining the Red Cross Division of Child and Adolescent Psychiatry from 2003 until his passing in 2010. He was also a prodigious researcher. He published more than 200 peer-reviewed journal articles, more than 70 books and chapters, and he led several large local and international studies, really groundbreaking research, especially in the area of adolescent mental health. He led some of the first big epidemiology studies on risk-taking behavior among adolescents in the Western Cape, and he also led the Mental Health and Poverty Project, which was a study focusing on mental health policy and services in 4 African countries, in Ghana, Zambia, Uganda, and in South Africa. He was also a very generous mentor and teacher, and many of us in the room benefited from his mentoring. I see Sharon Kleinkies is there. He supervised 24 PhD and master's students to completion during his career. He was incredibly generous with his time. He always had time to speak about our struggles or our particular research questions. I remember in the final stages of my PhD, we were attending a WHO meeting in Oslo, and he sat with me in a coffee shop till 11 o'clock one night, going through drafts of my final chapters of my PhD with a pen and saying, put this there, and what have you thought about this, and really helping me think through the research process. So I think many of us were privileged, and I think it's fair to say that many of us are not always aware of the giants whose shoulders we stand on, and I think this is an opportunity to really celebrate Alan, who was really a giant in the field. He also had unflinching integrity. He was really strong on research ethics and making sure that every research question you developed had a strong ethical basis for it, not just that it was sound methodologically. And this came through in his personal interactions. He was very fair, even-handed in the way he dealt with difficult situations. He was also devoted to his family, to his wife Meronisa, and to his twin children Adam and Kalela, and that also came through repeatedly in all of our interactions with Alan. So I just wanted to say a huge thank you to Kat and Ashraf and Claire and the whole team at the Centre for Public Mental Health for keeping Alan's memory alive, for providing this annual opportunity to celebrate his work. And I'm going to hand over now to Claire, who I think is going to introduce the speaker. Thank you very much.
Thanks, Greg. Well, it gives my great pleasure today to introduce Dr. Victoria Mutiso from Kenya. She's a clinical psychologist and head of research at the Africa Mental Health Research and Training Foundation in Kenya. She is a distinguished researcher, teacher, and global mental health leader who has been very supportive of our centre's work and capacity building initiatives over the years, which we've really appreciated. Dr. Mutiso's research interest is in child and adolescent mental health, development and adaptation of culturally appropriate interventions around promotion of mental well-being and prevention or delay of onset of mental health conditions in young people, as well as in underserved and marginalized populations in urban and rural settings in Kenya. She has experience navigating the Kenyan political and bureaucratic terrains, and with this experience has successfully engaged with the Kenyan county government to integrate mental health services at primary care level, which is really a great achievement. She has been principal and co-investigator in several mental health projects at the foundation and with other Kenyan and international collaborators, particularly on mental health and substance abuse, which are the basis for policy and practice in Kenya. In addition, she has several publications on various aspects of public mental health. In Kenya, she really has a very wide research interest and experience. So thank you, Dr. Mutiso. We are excited to hear your talk.
Good afternoon to you all. Thank you so much for having me. It's a great honor for me to be part of this great occasion. Thank you for the team that organized my travel and all the logistics. It's not easy to even just have one person being organized to attend this lecture. Thank you so much, Claire and the team, for having me and finding me fit to be the one person to come and deliver this lecture and to just stand here amongst, being among the one who has shared this platform of presenting or talking about the Alan J. Flisher work. And I'm really delighted to be that person who has been selected to deliver this lecture. And before I start, I would like to, give my homage to the family of the fallen hero, Elan, whose work still lingers on. I didn't know him personally, but when I got the invitation, I went over to my director's office, Professor David Ndete, and I asked him, "What do you know about Alan?" And he looked at me and he said, 3 things. One, he said, I knew him personally. So he was a friend of our organization and a friend of my director. And then he said to me, the second thing, I knew Alan as a family man. And I said, what's the third thing? And then he said he was really meticulous. And he said to me, I'm not sure how he handled those 3 things. All I knew is that his work still lingers on, and there are things that we do, actually most of the work we do sort of mirrors, if not exactly what Alan Flisher lived for. And I'm hoping that the family still will still work to ensure that that legacy lives on. And I'm glad the colleagues and staff at Alan J. Flisher Institute will make that banner to still fly. And those of us who are coming after him, I'm hoping that we'll keep the public mental health banner flying high so that his voice can still be heard beyond these borders. So thank you so much for having me. And for the next 30, 40 minutes. I'll be presenting some of the work that sort of mirrors public mental health interventions. That is what our foundation was founded on. So I'll give you a little background about who Africa Mental Health Research and Training Foundation is all about. It was founded or conceived in 2000 by our director, Professor David Ndete, who's a psychiatrist and emeritus professor at the University of Nairobi. We were formally registered in 2004 as a non-governmental organization in Kenya, but we have found ourselves working beyond Kenya and globally, really. We were formed to conduct research to inform policy, and as we will see from two of the models that I will be presenting today, to inform policy and practice in mental health. We are committed to conducting innovative implementation research that seeks to provide most affordable, available, appropriate, accessible, and stigma-free mental health services, all the way from family, community, and finally integrating mental health services at primary health care. That's our small institute, and that team on the right there is a team of psychologists, social workers, and some of our collaborators in the background of our project that was recently funded by the National Institute of Mental Health to do genetics and imaging work. We spoke about that in the morning when I went to meet Professor Dan Stein, and I'm glad to see very many faces in the audience who I have met, and our organization is happy to have partnered with over the years, and hopefully that we can stay connected and have more friends and partners and stakeholders and collaborators in this work as we go along. So where have we come from? As a foundation and researchers, we have come from a place where we wanted to change from the idea of just the researchers spearheading and talking about what needs to be done and throwing away all the ideas and the visions of other people and really steering the way. But we have come to a place where we appreciate everybody's input. Looking at what are the pros and cons of what we do and what do you think we need to do to get there where we want to be. So we have come to a place where we do what we call theory of change workshops and have everybody's input so that they can tell us where do they think they want to be and where do we want to be as a team. So with that background, then we have been forming very many groups, national steering committees that has the PIs on it, the Ministry of Health and other government officials, the civil society, human rights and government departments of social service, and any other relevant government officials. We also have county steering committees that's composed of technical teams from primary health, nurse, clinical officers, nurses, county mental health coordinators, county representatives of faith and traditional healers, including Christian and Muslim faith healers. We also go down to the sub-county health management teams that are composed of the second level of county health teams. Health facility management boards that includes the chiefs, the village elders, community opinion leaders, community health extension workers, health facility in charges, and members of county assembly as representatives and other NGO representatives. We also go down to the community health at location level, local administration and special group representatives, going again to the village health committee. So just making sure that everybody is included and is a contributor to the vision going ahead. And this is in a way to ensure sustainability, inclusion, and so that when the funding runs out, then the community is aware and is part of that vision and the idea. So where do we work? I am not going to take for granted that we might have people in the room or even others joining online who do not know where we are. Kenya in 2019, according to the National Bureau of Statistics, we had a population of 47.6 million, 23.5 million were males, and 24 million were females, almost at par. There was an estimated projection to reach 63 million by 2030, according to the Kenya National Bureau of Statistics. But there is word that the fertility rates are going down. So we will see what happens when we do the next census. So what's the mental health context in Kenya? There's only one mental health specialist for every 1 million people in Kenya. And according to the statistics, out of every 4 Kenyans experience a mental health condition in their lifetime. And I'm sure that's what pertains in other similar contexts. The most frequent of the diagnoses made at primary healthcare level is depression, alcohol, and other substances of abuse, as well as anxiety disorders. Now, Kenya was ranked 5th among the African countries with elevated levels of depression, approximately 2 million people suffering from depression. With that background, before the outgoing government left office, a mental health task force was set up to investigate why this was the case. So that is still ongoing, and the report was launched that last year to just look at what is happening on the ground. We indeed had a high level of suicide cases than ever before in the country. So a mental health task force report was presented to the country last year, and a bit of what the recommendations were from that report is being implemented currently. We do know there is a high treatment gap in low and middle income countries. And that's one of the gaps that we have been looking at. And this, over 75% of people with lived experience of mental illness do not receive the treatment they need. And when they receive the treatment, is not adequate to actually ensure quick recovery. And leaving those people without meaningful community participation, inclusion and integration, and poor quality of life. We know they experience high rates of stigma and discrimination with a context that is characterized by mental health services that are offered within only institutional settings, and these institutional settings are only found in urban centers. There is no consideration for social, cultural, and economic factors that really are some of the social determinants of mental illness. There is lack of employment-focused services, limited employment opportunities for people with lived experience, and there is also limited retention job opportunities and accommodation for people with lived experience of mental illness. Stigmatization and discrimination. There's abuse of basic rights. They are subjected to inhuman treatment, both at community and health institutions. There is inability to access quality basic health care, loss of jobs. As I said, there is lack of retention of job opportunities, and the inability to engage in useful economic activities. There is neglect, abuse at family level and community level, often with persons with mental illness left on their own without any form of support. There's loss of property, especially at family level. Thank God for the Convention of Rights of People with Psychosocial Disabilities, at Article 12 of the Convention, that's looking at the right of the person with mental illness. And there's also lack of information and lack of support. I have a link there that I like to play whenever I have time at the end of the presentation. So I'll leave that as a space folder. Once I have time, we can go back and share. So in 2015, we launched the Kenya Mental Health Policy. And for us, that was big because it has been 15 years when the civil society has been agitating for a mental health policy that talks about the rights of people with lived experience, that has the voices of the civil society, that has the voice of the public, that has the voice of the family, and that has the voice of the business and has the voice of the family and the person with lived experience. So there has been a mental health policy, but it was very, very clinical and very institutional based. But this is the first time, and we are really excited to be part of that conversation. We launched this in 2015. We have already made the implementation framework, and some of the 47 counties in Kenya have begun to implement the mental health policy. So for us, that was a big, big achievement because we are in that space and working together as stakeholders. So I'm going to talk about two models. This is one of our models that we started working on. Well, some of the ones that we worked on for a couple of years. We called it Create Kenya. Create is both an acronym and a word itself. As an acronym, it's community recovery achieved through entrepreneurism. And it's also Create Kenya because we created it from scratch with stakeholders, a lot of stakeholders, and I will be talking about that. So Create is a paradigm for recovery from serious mental illness that couples social business, which is what I will be talking about in this presentation, that focused and culturally informed psychosocial rehabilitation practices and peer support. So we worked with a great psychiatrist, friend and colleague from Western University in Ontario, Canada, who was a PI, and I was co-I on that project, and David Ndetei was also co-I on the same project. So on the social enterprise model, because I said we had two components on that project, which was graciously funded by Grand Challenges Canada, we called this part of the model Beyond the Clinic. We recruited and worked with individuals outside of the hospital setting. So our major goal was to establish a multifaceted social business with peer support within and without. From the psychosocial toolkit, there were components of illness self-management and social inclusion and participation in community that had involvement of carers and families and people with lived experience. There was also economic empowerment, where we set up a print shop business in the city to provide real and meaningful employment for people with serious mental illnesses. We developed an evidence-based psychosocial rehabilitation toolkit to facilitate recovery. And recovery, as we know, is not without symptoms, but how people with lived experience can function even with symptoms. And that is within a LAMIC, low and middle income country context. So the psychosocial rehabilitation toolkit was locally designed with input of people with serious mental illness, their carers, community, business members, and indeed the clinicians from the hospital where we recruited our employees from. This was contextualized and reviewed locally by members of the team who are people with mental illness, their carers, and family members indeed were very, very instrumental in developing this kit. And this was to increase their capacity to be satisfied in their social and working environments, even with symptoms. So the CREATE strategy was to bring the social business and a recovery-oriented psychosocial rehabilitation toolkit together so that we can be able to measure the clinical and social outcomes as well as the social business outcome. And this was on an ongoing basis where we recruited stakeholders in consultation and continuously engaging them as we continue to refine the CREATE strategy. So I'm going to talk about the point tech component of this model, which was very, very promising. We provided employment to 15 people living with serious mental illness on full-time, and some of them were part-time, and others on commission packages. This dependent on accommodation, as I said earlier. We accommodated each of the employees based on the point at which they were, the phase at which they were in the period of their recovery. We created awareness about mental health recovery within the city through active participation in various events, the World Mental Health Day, any business forums. We found an opportunity to present our case, and which was organized by like-minded individuals and organizations, as well as government ministries. So these were some of our stakeholders that were involved in that work right from the beginning. We went to the streets to talk about and to ask the public, what would they call a business, or what would they like to see the name of the business of people who are recovering from mental illness? If I present the slide of the names that we got, it was full of very stigmatizing names. Recovery, names that were very, very stigmatizing. Until at last we said, okay, so we will go outside of the city and get a name. So this name, which I will be talking to you about in the next slide, was born out of the interest and the experiences that people with lived experiences had. We asked the people that we were recruiting what they had interest in and what they had experience in. So we had a number of people who had worked in print shops, they have worked in cyber cafes, they have worked in stationery shops, and that's how we came up with the name Point Tech Shop. Really, really exciting for us. So the 15 members of that shop are the ones that were included in that shop, and it was registered, and we hit the ground running. So we had very many capacity building sessions. They were about bookkeeping sessions, human resource, typekeeping, marketing strategies, because not all of the employees would sit at the shop to provide the service. But they took turns. Either they went out to government ministries to look for job opportunities for us to supply stationery, or if they had bulk printing to be done, or if some schools had bulk printing to be done, or some small organizations had registrations to be done. So they shared amongst themselves, and who was going to even be the bookkeeper and the individuals who would bank the money the same day. There was a reason why we actually set this shop in this building. It was because the same building, there was a bank on the ground floor. So the good thing is that, and that was very, very exciting for us, the bank allowed our staff to bank the money even after office hours. So they were allowed in to go through the back door with security to deposit the cash they had collected that day. So that was really, really exciting for us. So this was the first team. We recruited 5 members of the business every 3 months. And we did this because we were recruiting them after they have left the inpatient care at the hospital. So we made sure that every time they have been discharged and they are ready to go, then they come through the print shop and they go through the continuous mentorship and the training sessions on bookkeeping, business, marketing, and all that. So these were our first 6 employees. And then on and on, we continued up to 15. We wanted to start small because most of the funding that funded the initial idea came from the donor, and we wanted to ensure that for sustainability, the funds that are generated from the shop can continue to bring in more staff. So we measured a number of impacts from employees with serious mental illness. There was an increase in personal sense of well-being, a more positive self-identity. We had a woman who was one of the employees and previously was not able to take care of their daughter, but this time she earned a salary, she was able to go to school and pay school fees. Increased productivity. Because of the timekeeping schedule, they felt that they were in charge of this business, so they would come to work on time and take their schedules and cover for each other's time in the event one of them needed to go for their refill. Financial independence was improved employment and social skills. They had a time together to look at how their day has been and how their week had been. So every day, they used to have 15 minutes of catch up and just ensuring that everybody was fine with the way things were going. There was connectedness with their family and the larger community. Where we set up this shop, in fact, the neighboring businesses gave us more business that they gave to other businesses because they understood from our lobbying and advocacy of this print shop, they understood what our business stood for. They were integrated in society. There was a reduction of stigma and increased levels of confidence, improved livelihoods because they got paid from the shop and they achieved goals that they had set out at baseline. Some returned to school. There was a gentleman in the team who had dropped off from the aviation college. So part of the proceeds that came from the shop actually paid for part of his tuition fee to go back to aviation. We also measured certain outcomes at family member level. They showed a sense of hope and pride for their loved ones because now they were no longer dependent on them. They experienced reduced financial and caregiver burden because of the psychosocial rehabilitation toolkit. Our employees were able to sit together and talk about their symptoms in a safe place. We also had a small space where we had hired from the proceeds of the shop, where we could allow other members of the public to come and have short-term meetings if they wanted to do their small meetings there of about 10 people. So proceeds from that hiring of that space also went to the care of the people with our employees. And in the event we needed to pay a little bit for their meds, then they were not paying from their pockets also. It was a bit subsidized. And then the family members also understood how to support their family member with serious mental illness using the recovery-oriented approach. As I said, we worked with the primary healthcare system. So they say they gained new knowledge and skills in the psychosocial rehabilitation toolkit and recovery-oriented care. They gained job satisfaction because they didn't see the revolving syndrome when the participants had left hospital. We actually measured how many times our employees went back into inpatient care. And over the duration of the time when the print shop peaked, and for 1 year and a half, we didn't have anybody going back for inpatient care. So that for us was big time, and we were really, really excited about that. They were eager to impact lives of other patients within the hospital through the delivery of psychosocial rehabilitation toolkit that we developed, reviewed, and adopted for our social context. How about the wider community? There was creation of awareness within the local community on the possibility of recovery and meaningful engagement of people with lived experience. There was stigma reduction, as I said earlier, social acceptance through awareness, and people were more inclined to the idea of talking about mental illness more than it was before. The owners of neighboring point tech shops, the point tech shop, were willing to learn more about how to support people in their recovery process and also in times of crisis. We had 2 employees from a neighboring business that opted to step in whenever our employees who were on duty that day needed to go and see the doctor. So we had a sort of a private engagement that if they need to go and see the doctor, if there is a bit of a crisis, they would step in. So again, that was really big for us, showed a lot of integration and inclusion and participation. We provided professional printing services from the shop. In fact, we had a feedback box outside the shop, and one of the customers noted that the staff had high levels of courtesy. We trained them on social skills and how to receive customers and how to serve them, and if there was a crowd, how do you manage the line? So this is one of our banners in the public mental health space. When we are working with our local hospitals, we like to just make sure our presence is felt. And so that's one of many banners. Before we rebranded, that's an old banner. It says Africa Mental Health Foundation. We are now Africa Mental Health Research and Training Foundation. And hopefully based on what we are beginning to do and get feedback from, we are rebranding and we will let you know who we will be. So I'm going to be playing a short clip so that you don't just hear my voice throughout.
My name is Mandela, and I was part of an amazing team called Team Major, and our job was to have a sustainability plan for Create Kenya and the people that were going through the PSR toolkit facilitation. And since we started, we had the idea of scaling up the plan for Point Tech, but through various factors and challenges, we had to go back to the amazing members who had already gone through the PSR toolkit facilitation, and they gave us amazing ideas as to what we needed to do. And one of the things was to support them in their small businesses and entrepreneurial endeavors. And we're here today talking to them and finding how we can support them and make this a dream that's achievable and both scalable.
Na nime experience na mambo ya magari upande ya radiator. Hiyo niko na experience, niko na mabarua, niko na kila kitu. Wakati nilishikwa na ugonjwa ndio nikawacha. Sasa hiyo nikivuvua naweza endelea mzuri. Sababu nilikuwa nimesomea sales and marketing na kila kitu. Naweza uza kitu, naweza nunua, naweza service na hiyo. Nilikuwa nimesomea hiyo. Kwa hivyo pande yangu ni hiyo ndio naona naweza fanya.
Hiyo kuku iko sawa. Na watu wakifanya wanaendelea
na space nafasi
iko.
The main takeaway here is focus on a business model that has everyone in the group work together. And one of the biggest takeaways was starting a car wash business, where each and every small business that these individuals would do on their own would play a part in the larger business, which was the car wash. Robin, Michelle, these have been the biggest players in this, and I really want to thank them for all the input and advice that they've shared with people like me. Even though they're in Canada, they've made this possible.
Just in case ujui, kila mtu hapa dereva. Tulijua mbele iko sawa. Wakisema ni kupagawa, tukameza madawa. Ona vile tuko sawa. Moja, akivunji chawa. Tushikane mikono. Sisi wote hapa. Imani duni zifike kikomo. Tujenge afya ya bongo.
My name is Sharon Lanois, your meet. I'm working with Global Minds, specifically a team called Watetezi that is focused on advocacy and awareness through creating an incubator for advocacy and awareness. When we actually did have our first meeting, it was mind-blowing how positive the participants were about what we were going to do, and that they had not forgotten the plan that we had told them about earlier in the year.
We had a lot of meetings as a group just to discuss what our vision of the incubator was or is to be. We did focus groups where we got people who had done the PSR toolkit to tell us what they think an incubator is, what they imagine it or what they vision it to be. We talked about the supports, the skills they would need. But ultimately, the preparation came with starting it. Yeah? With the incubator, it's all about the people living with the mental illness, empowering them to be all that they can be, to be the change in the community. It's not us to bring the change, but for them to bring the change.
When the team talks about their issues and their experiences, the team in itself is strengthened. So that is one of the impacts that the team had, the incubator had on the participants. The whole communication and creating a group to try and plan other things surprisingly made them closer, gave them less self-stigma, and also reduced the way they perceive the stressors in their lives.
My name is Mumbi Chege. I'm a member of Team Visibility, and we have just completed the training of an orientation of our visibility volunteers. Our team had a two-pronged approach to this. We wanted a volunteer network, and we wanted to train the volunteer network about awareness, to raise their conscious, the group conscious about mental health, mental illness, people with psychosocial disabilities, such that they on their own stand as beacons, as champions. And then the second part of our solution, our project, was for the trained volunteers to now go forth, run activities, create safe spaces where people with and without psychosocial disabilities would be able to interact, mingle in a fun environment. We believe that activity bonds people closer than just speaking and just not empty, but just verbal awareness campaigns. We believe our model is very scalable. We started with a university population in a university town. We have maybe 10 other university towns, and very soon every town will have a university population, and we'll spread it. So our vision is we conquer Kenya, we go East Africa, we go Africa, we go the world.
I'm a visibility volunteer, so happy, so excited for that. Training was so informative. I interacted with new people from different places, visibility volunteers who've been in visibility for some time. The training will have really great effects because, one, people are getting more aware of mental health issues, and this awareness we're getting is the same thing we're taking outside to community members.
My name is Miriam Munir. I work with Team Tumaini Kenya. Our group came up because we needed to focus on how to help the community improve reintegration through follow-up care for mentally ill persons or patients suffering from mental illness. And our community partner, we chose Machakos Level 5 Hospital, specifically psychiatric ward. Their support has been tremendous. Like they always show up. They assist us with preparing the toolkit, which is the main tool we are using to pass the information on mental illness, to educate both the professionals and the community. So we will focus on family, since aftercare mostly involves the family, where the patient goes back home to. In cases where they have no family, we focus on the community itself because they have to be employed or start businesses. We were able to do the toolkit, which we will use to educate the families. But we realized that our first toolkit the outcome would have resembled another team. So with advice from our mentors and the stakeholders and our community partner, we're able to sit down and restructure a new toolkit, which is currently what we are working on.
Okay, so based on what we did with university students, the community members and family members, we had very many groups come out of that incubator program. And some of these are the initiatives that came out of not just the print shop, but we also, as I said earlier, looked at what other interests and experiences that the members had. So we had the chicken business, we had the tree planting business, we had the egg selling business, and this one right here, which is also part of what I'm wearing today. So I'm really excited to be part of that team. So we saw a rapid re-entry into the workforce, and we capitalized on individual and family strengths, preferences, and interests. We worked collaboratively with people with lived experience to provide real employment opportunities, and we linked mental health and employment support directly to active work opportunities. We created conditions for prosocial contact with the public and meaningful participation in nation building. And the newest kid on the block, is a book which we released early this year with the team members, A Taste of Kenya. We are really, really excited about this because it's a book that talks about the recipes and stories of what they can do best. So it will be on Amazon shortly. So I pray, I'm their marketing manager, so hopefully you can buy some of that and see and get to taste some of the recipes. So I'm going to be talking about our next model. It was a transition to scale funded by Grand Challenges Canada. We called it multi-sectoral stakeholder team approach. So we named it teams because it had many teams on it. I was the principal investigator. David was the next lead, and we had this brilliant and fantastic colleagues from the Global Mental Health Program, Professor Catherine Pike, who some of you may know, and Tahilia Ribelo, who I'm sure some of you might know. So our goal was to integrate mental health services at primary health care with government, informal and formal services, and to pull all those resources and experiences together to integrate mental health at primary health care. These are some of the teams that were involved. We had community awareness to fight stigma. We had traditional and faith healers. We went to churches, we went to schools, and we went to government offices to really lobby and advocate for budget inclusion in the county government budgets for mental health. So we had a chart there. It might not be clear to everybody, but each of those teams, we trained them on the WHO mental health treatment intervention guideline to identify individuals who had possible symptoms of mental health problems, and then they were referred to the clinic for the confirmation of symptoms, and then there was treatment, and we measured at 3 months, 6 months, and 9 months. So we measured symptoms at patient level at outcome measures. We used the WHO quality of life, and we also had system level outcomes. I won't go into that. I think we are running out of time. We had a strengthened default training system, tracing system, and we used all manner of transportation depending on the terrain. So we had support from Grand Challenges Canada to, support the health systems in trying the best way we could bring the family and the patients to the clinic for detection and treatment, for confirmation of diagnosis and treatment. This was a summary of the screens. As you can see, the community health workers did most of the job. So the community, these are the teams that worked on on detection and identification of simple symptoms, and then they referred them to the clinics. And you can see the community health workers are the ones with the majority of the positive screens and symptoms. So the positive screens, this includes positive non-shows, those who didn't go to hospital, and positive shows are those who presented themselves to the hospital. So we have some results to show, very, very exciting. According to the PHQ-9, the depression scores really changed over the course of the 3 measurement periods. And then we also used the assist alcohol, and so there was alcohol changed over time, except at 6 months, it didn't have a sharp decline, but there was a difference anyway, which was not statistically significant. Tobacco didn't change after 3 months. Slight change, but there was a statistically significant difference, both with alcohol and tobacco at baseline and at 3 months. For epilepsy, we also measured epilepsy. These were the total number of days with any seizure for the last 28 days. So seizure-free days, and then the longest period in days between which a seizure occurred. So the red line is the total number of days that the participant took his or her medication as prescribed. So this is just a summary of how the depression scores and psychosis. The depression scores reduced significantly across all the assessment points, as I mentioned. Psychosis and affectivity again reduced significantly across all the 3 time points, and the mini mental state examination improved from baseline up to 6 months, but not at 9 months. We're not sure what happened. But anyway, at 3 months and 6 months, there was a certain level of improvement. And across the time points, alcohol use decreased significantly. Epilepsy and suicidality did not statistically improve over the time. Sometimes it got really nasty. We got a very bad accident as we were trying to chase data. So it's not usually all rosy. So we didn't get to see that there was this truck and our van rolled. No one was hurt though. But we continued with the trip after we had been told. And sometimes we got to the river and the bridge has been swept away. However, it's not all gloom. We present data and it goes to the decision makers. I remember this day with nostalgia. Just before I took the podium to present our exciting results to the county government, this is sort of the president of that county, and some of you might recognize this, this face. This is Peter Singer, who was a former president of Grand Challenges Canada. He heard about our results and came down to just see exactly what this is like. So just before I took the podium, I received a call. And I was told my mother had passed on. As I was going to present results on public mental health. You can imagine how that was. However, it gave me the push to present the results. And voila, 2017, mental health was fully integrated at primary health care level. And just when we received that news, 2017, so this was 2016, 2017, it's amazing. When we were receiving the news that the county presidents of 2 counties have accepted and the county assemblies have funded mental health at primary health care, again, I received a call that my younger sister had passed on. oh, what public mental health can do. But, we got the zeal to move on. For me, and family, we owe it, to the fallen heroes, just like Ellen, and hope that the same vigor, determination continues and the voices continue to move on. Out of that work, we have had 10 publications coming out of that work, very, very exciting. Some to find themselves work into great journals with high impact, changing patterns of mental health in rural Kenya, feasibility and effectiveness of primary healthcare staff, feasibility of the WHO GAP guide in reducing discrimination and stigma, patterns of concordance, perceived impacts, predictors of intimate partner violence, using the WHO aims to inform development of mental health symptoms and towards community coverage on self-screening. So, together we can shine and everyone can join in this journey. Thank you very much.